organizing secretary, for giving us the opportunity to present our IC on rock hard cataracts, and we have a wonderful faculty here. I'd like to introduce the first speaker, Dr. Haripriya Arvind. She's a prolific surgeon and probably the surgeon who has the maximum number of cataracts under her belt. And unfortunately, there are not many people to hear him, so I'm sure more people will join in. So on to Dr. Haripriya Arvind.
Thank you so much, ma'am, for this opportunity. It's always a pleasure to be a part of your course. So I'm going to be talking on phacoemulsification in white and hard lenses. So we'll just go to the white cataracts first. The challenges would include the absence of red reflex. So the first biggest challenge is to do a rexus, and the second part is to do the phaco in these white lenses. The raised intralenticular pressure also makes rexus difficult, and this one has the liquefied cortex. Also, once we begin, it's difficult to gauge the nucleus density. So one quick tip is to look at the patient's age. If it is a white lens in someone who's younger, like less than 60, it's typically a softer lens. But white cataracts in older individuals are more hard. Zonular weakness is something we should anticipate in these patients, and there's an increased chance of complications as well. So some of the aspects how we could address these challenges: capsular staining is a must. Cohesive viscoelastic also helps a great deal, especially in intumescent lenses. And we normally would like to make the rexus a little small, at least initially in these intumescent lenses, so that it doesn't extend up to the periphery. You can always do a double rexus later on, or spiral it towards the end to enlarge the rexus side. I also prefer to or side pole. In intumescent lenses, the forceps is very useful. I don't do a hydro because that will only loosen or you tend to lose the whatever little cortex you have. I'm doing a horizontal chop here. It's a soft lens, so young patient in the 40s. So in these soft lenses, a horizontal chop works well. We use a straight chopper with a blunt tip and move it from the periphery towards the center. Very less and low vacuum flow, because you don't want to. So you use less energy but use more mechanical forces. That's why the chopper, the blunt tip chopper is useful to separate and to feed the pieces towards the phaco tip. Now this is a little harder cataract. It's also a smaller pupil. Now with these patients, again, I think in a small pupil the chop technique works very well. The rexus has to be a little larger than the pupil size, so you may have to do a little blind rexus. If not, always go in for hooks before you do the rexus itself, so you have more working space. With the small pupil, the chop again works well, and here it's a vertical chop. So this is a straight chopper with a sharp tip. This is Dr. Mohan chopper, and I use this for the vertical chop for all the firm and hard cataracts. So being a small pupil, you would like to keep your phaco tip in the center. So a little, you just kind of impale in the center, hold it, and then move the chopper either vertically or diagonally, slightly in an angulated fashion, so that the chop is complete. So you also have to break these fragments into small pieces. The reason being, you also have small pupils, so when you bring it into the anterior chamber, there's less trauma. Also, when you emulsify, it's easier to emulsify if you have a smaller fragment. I would like to normally chop the fragments first and then eat up the pieces, because otherwise you'll find you will not have much stability on the sides to chop. So chop first, then at that point in time you'll have the other pieces to stabilize, and then you can eat it up. The drawback may be that you may have some free flying pieces, so ensure you only take the piece one at a time. And if some piece does fly in the anterior chamber, get that piece first and then go to the other pieces in the capsular bag. So the pupil being small, one full device is using the white hook or the Kruglan's hook. So use this if you're using coaxial INA to retract the pupil and then aspirate the cortex in these eyes with small pupil. In hard lenses, the challenge is that it's you tend to have very densely compacted endonucleus and very little epinucleus around it. Again, the capsule is thin here, so again a higher chance of PC rent. Again, this is more common in older individuals, so you'll have to use a good elastic. Use either something which has conductant sulfate, either Viscoat or Autocoat Plus, something which has a good dispersive to coat the endothelium. That's a must for these hard lenses. And again, this correlates well in terms of nucleus color and the patient's age. Both these are factors which correlate. Another risk factor for hard lenses is also the myopic status. So a patient with higher axial length also tends to have a harder cataract, even if it's a young patient. So the prerequisites would be to have a tight side port incision just to enable good fluidics. So you want to stain the capsule, you ensure the nucleus is mobile. If possible, you can make the rexus large and do a good hydro as well. I mentioned about using the dispersive OVT and also have more of the phaco tip exposed when dealing with hard lenses. And the vertical chop is something which I prefer, again, more so in hard cataracts, because there you don't put as much stress on the zonules and you tend to have your phaco tip in the center and you use less energy as well. So in a hard lens, I like to make a larger rexus. The reason being, you have more working space. It's, hard lenses, the capsule also is thinner. So it is not difficult to make a large rexus. Use stain wherever possible. That gives you better visualization. Before I start, I like to make a small little burrow, little trench there, and then impale deep. So if you look at the phaco tip, it's retracted more posteriorly. So at least about 2 mm of the tip is exposed. And complete the first chop. So again, impale deep and complete the first chop and then continue for the rest. The other aspect is, if you look at the tip, it's shiny and new, so like to use good tips. So if not, you can't use a new tip for each case, but have a few fresh tips available for these hard ones, because that way you'll find you're able to hold deep, because only if you hold deep can you break the posterior leathery fibers. Otherwise, you'll have the central core still intact, so you'll have to hold on the lower half of the nucleus. So you trench a little, make a little burrow, hold deep, and then chop. Again, this is the same Mohan chopper. Use this, a long one. You have different sizes, 1.75 millimeter or 2 millimeter chopper, and then sub-chop it into small pieces. So here, again, the reason is, once you have a large piece, that to take in that kind of a large piece, you will use more energy. So smaller pieces are easier to pull in, and that means less endothelial damage. I'm using OSL, I'm using torsional ultrasound, but if you're using longitudinal ultrasound, you can use the pulse or the burst mode also in different modulations. So pausing also will reduce the chatter. What is critical here is to have a good chamber stability. This is a hyper-mature cataract. So hyper-mature cataracts, they are white, but we all know the nucleus is going to be hard. Especially, if it's been, so this kind of a cataract, you're not sure how the nucleus density is, but you can almost always be sure it's going to be a very hard nucleus. And this can be one of the most challenging cases, right from your rexus to the actual phaco per se, because the nucleus is mobile within the bag, and the bag is also weak here. So you will focus on making a large enough rexus, not too large, but just enough to do your chop at least about 5 millimeters. You can see how the nucleus is moving to one side. You can't actually trench here, so you can't do a divide and conquer in this. So you'll have to lollipop the nucleus, hold, so use good vacuum. You have to use high vacuum while not ensuring any chamber fluctuation. Have to use high vacuum and flow to hold deep, continue with your foot position to build the vacuum, and you separate like fiber by fiber. You can't be forceful because the bag is also weak, capsule is thin, so you are very gentle. From above you go and try to do it at different planes. All the time continue to hold. In case the chop is not complete, I would tend to re-impale at the same site. Instead of going to the adjacent next site, I would go back at the same site. I would hold there, hold deeper, and then repeat the chop. So complete that chop first and then go to the next piece. And if you are, if you lose the hold, again re-impale, build vacuum, hold it well, and then place the chopper from above below. So it's a vertical chop or a horizontal if you're going to do the sub chops. And with this separation, usually this bag is free, so it's fine. But because it's free, again you have to chop first completely and then only remove the pieces. So you make it into these small fragments here. And And as I said, very important, because most cataracts, chamber stability is important, but much more when dealing with hard and hypermature lenses, because here your PC is bare, so it can trampoline forward. So you'll have to ensure you have high enough settings, but not too high that it's going to cause the PC to come forward and cause a rent. If that happens, and especially when removing the last or second last piece, bring your vacuum down to a safe level so that you don't have a posterior capsule rupture. And like I said, you also want to keep it lower, the phaco tip at the iris plane, not bring it too much to the cornea. But using this viscoelastic, this does help a great deal when dealing with these lenses. So in conclusion, the different aspects one has to look at is to have a rhexis, which is absolutely mandatory. Good viscoelastic, a vertical chop technique is useful. You should use adequate energy. There's no point trying to use less energy and prolonging the procedure. Use adequate energy and high vacuum and flow for these brown lenses. Good fluidics. And if there is a conversion, if there is a need, there's a complication, one has to prepare for conversion, because these pieces can also drop quite quickly. There is no epinucleus or cortical bowl which supports it, so you'll have to react soon. Thank you.
Thank you, Dr. Haripriya. That was a very fantastic talk. I just have one question. In case of white, mature, hard cataracts, which are intumescent also, do you have your own special technique to prevent an Argentinian flag sign?
Yes, so I would obviously use a high molecular weight viscoelastic, whatever you use, Helon or Provisc or whatever, the first thing. Second, I would tend to make the rhexis small. And I would like to curve off, so I make the incision and the nick, and then try to curve it off initially itself instead of making it more linear, because this way you would prevent an extension. So once it is done, I would then use the forceps. I use the forceps which Epsilon makes, the micro-rhexis forceps, which holds it's a titanium, 2.2, and that is very useful to grasp and then complete the rhexis. So the only drawback is your rhexis will be small. So you can do two things. One, as you're completing, you can try to make it larger if your liquefied cortex is out. If not, complete the rhexis, do a hydro wash of whatever lens matter is liquefied, and then put visco, make a small nick with the vanas, and do a double rhexis. So this is what most of us would do. But trying to keep your rhexis small is the most important aspect, I would think.
Have you tried punctorhexis or?
I have not tried it.
Or needle aspiration?
No, I have not tried. I think with this technique, it seems to be working. Okay.
So you do a double rhexis basically. You
if required, yes. And I do most of the time. I do it only after lens implantation or before lens implantation, because if you're doing a chop technique, a small rhexis also works. But depending upon the rhexis size, one can choose to extend it earlier or even later in the procedure.
Any questions from the audience?
The only problem with the double rhexis is that if it's sometimes very small. So what I normally do is to wrench a little bit. So the problem is there is a pressure behind the nucleus as well, which is pushing the nucleus forward. So you just debulk the nucleus slightly and then try to enlarge it.
That's a good point. Yes. You'll have to debulk, otherwise there'll be lens.
The punctorhexis works very well because it decompresses the anterior segment, that is the anterior component, as well as the posterior component. There are actually 4 components working in this. But amazing videos.
Regarding the viscoelastic, what do you use, the soft shell technique?
I use the soft shell technique, yes, but I don't use I use with HPMC, which is a modification. So I use either Viscoat or Oricot Plus with HPMC. That works well because this also stays. The HPMC stays, and it is also easy for the rhexis. So that is what I do.
Any tips to prevent corneal burn? Because when we do hard cataracts, particularly, I'm sorry to say this, but I know you're a fan of Infinity and Centurion. I find that most of the times when I handle Centurion or any of the Alcon machines, I find there's the chance of corneal burn is higher.
Okay. The reason I tell you, because...
That's why. Do you have any tips to avoid corneal burn?
Nothing in specific, just that, we have to be, I'm sure this doesn't happen to you, but someone who's in training has to ensure that the tip is in the center of the sleeve. If the sleeve is too tight and the tip is slightly eccentric, that can probably cause a wound burn. But I think today, thankfully, most machines, we don't see it as much.
The reason why it's more common with Ozil is that because if you don't aspirate the viscoat, okay, and
That is a
try to do
good
the
point.
phaco power,
Yeah.
see, because the viscoat occludes the nozzle tips very fast, and the heat gets transmitted to the cornea immediately. So please aspirate the viscoat a little and then try to do the drenching. So that's one thing which we have learned over a period of time.
Actually, that's probably a factor because we don't fill the AC with viscoat. We only use it to coat. And then also with hydro, we try to bring out as much visco as possible. So maybe that is what is helping us to as well.
In Centurion, do you have any specific parameters like what will be your bottle height and?
So because of this, we use the active sentry and we have the IOP. IOP we set it with active sentry at about 40. Up to 44, depends upon the things. And vacuum could go up to 650, 600, 650. And flow rate 38. That is what we use.
Any questions from the audience?
Any questions from the audience? Anybody asking?
I'm sure all of you are dealing with hard cataracts, brown cataracts on a daily basis. And nobody better than Haripriya in this.
Sir?
Is pre-chopper any of help in this?
Pre-chopper, yes, I think it does help, but these very hard ones are not very easy to pre-chop. So I think Dr. Akahoshi is the pioneer for pre-chop, and he does have a technique.
The Myo-ring and all that.
The Myo-loop also helps.
Myo-loop.
Yeah, but I think those all have a learning curve. I mean, the Myo-loop also, I think it works in some people's hands. I tried it, I didn't find it very easy to use. But there are many innovations coming. And the pre-chopper, there's a combination. He uses two instruments. Instead of one, he uses two for a pre-chop and a hard lens. So it is a skill which you have to acquire. So it's not as easy as it looks when Dr. Akahoshi uses it, especially in hard cataracts.
Would you, in any case, I mean, everything being fine and only the cataract is very hard, would you say, okay, this case we need to do SICS, not phaco? Would you do that, or you'll do phaco every hard cataract?
I think in today's scenario we do it, except maybe if it's a compromised capsule, like a poster capsule is a traumatic and then the poster capsule. See, with SICS, your forces are more upward, so it is safer. With phaco, with your probe and everything and hard nucleus, with the chance of dislocation, with the fluid itself, things can go down. So those may be some of the cases where I would prefer to do SICS.
Any other questions?
Pre-chopping may probably is a good question actually, but what the femto, which I'm going to talk about, does the pre-chopping beautifully. The problem with the pre-chop, Akahoshi pre-chop, is that in very hard brown cataracts, again you have to give so much of lateral separation. There's so much of stress on the zonules and on the PC as well. For grade 2, grade 3, it works very well. But beyond that, we are talking about grade 4, 5, 6 and all that. Yeah. Very clear, fantastic.
Thanks, Haripriya. Thank you. Directly we can do it. It's okay. Can we start? So once again, I'd like to. Is it coming on?
Will come.
To thank the organizing committee for giving me this opportunity to conduct the course on rock hard cataracts easy way. So these are the faculty. We have already heard Dr. Haripriya, and Dr. Mohan is also a prolific surgeon, and he has presented in several national and international conferences and is authority on cataracts and particularly hard cataracts. And we have with us Dr. Nivian, who will be joining us. He's young blood, has a lot of experience, and is an innovator as well, and he'll be speaking on management of subluxated hard cataracts. So my topic is on small pupil and hard cataract. And nowadays we see that post-COVID scenario, I think almost all of us are seeing quite a lot of hard cataracts. what we never used to see before. Initially, when we started phaco, we used to see a lot of hard cataracts, but now the hard cataracts was only about 10% of our practice. Now it's a reversal. We see quite a lot of hard cataracts, and this is a very common scenario now. Pupils not dilated, very small pupils, very hard cataracts has become a very common scenario post-COVID. So the causes for small pupils are long-term use of miotics, pseudoexfoliation, prior iritis with Sinicaid, trauma, diabetes, or it could be just poor mydriatic application. It's associated with advanced stage, advanced nuclear sclerosis. And there's a specific condition called Interoperative floppy iris syndrome, where there's a triad of intraoperative signs with iris billowing and floppiness, iris prolapse, and progressive meiosis of pupil. This happens due to the lack of tone of the dilator muscles of the iris. So the preoperative management would be to stop miotics, use long-acting mydriatics, and give a peribulbar subtenon's block in these patients because you are anticipating some problems. So intraoperative floppy iris use high-density viscoelastic, but even then it's always better to anticipate this problem and probably be ready to have a pupil expanding device like iris hooks. Use low flow. If you're in the middle of surgery, you can use low flow parameters in vacuum and aspiration. So this is a challenging situation. You can see the cataract that I am operating now. You can see that I'm removing all the Sinicaid. This I did about 10-15 years back, and before even the iris hooks came, and you can see I'm stretching the iris. This was one technique that we used to handle very small cataracts. And after stretching, we get about a mid-dilated pupil. The other one is a uveitic cataract with the posterior Sinicaid in the pupillary margin. Again, these cataracts are they're quite difficult to handle, and they can be handled in different ways. Nowadays, we have excellent pupil expanders, so we don't have to go in for the stretching the iris, because that can cause the iris to become loose and floppy and can actually present itself in the phaco probe. So this is a fibrous pupillary membrane, which we're using actually a vitrectomy scissors to cut the pupillary membrane. So the management would be a pupil stretching using iris hooks, pupil expansion rings. You can use intracameral adrenaline in patients who have not been dilated, and using high density viscoelastics. And this is a case of a very hard cataract with a pseudoexfoliation, non-dilating pupil, and so decided to go ahead and do use iris hooks. For me, the most important thing is that I prefer iris hooks in most all my cases. I do use other pupil expansion methods occasionally. So we have made 4 reports. There are people who use 5 iris hooks also. But 4 is actually quite sufficient. Less than that may be difficult to operate. So now with the 4 iris hooks inserted, you've got a nice large square pupil. Now you can make a side port and inject a very high density viscoelastic, because you want to stain these capsules. Very important that you stain these capsules. If you use HPMC, you cannot stain the capsule. So I've used a high density viscoelastic, and I'm staining the capsule using trypan blue, and then going ahead with the rexes. In these cases, like Dr. Haripriya previously said, make a slightly larger rexes than you would normally do, because you don't want any stress on the zonules. Because already patients with pseudoexfoliation do have a chance of zonular dialysis. So making a larger rexes will give you more space to operate and less stress on the zonules. And so you can do a multiple quadrant hydrodissection, do a central trench like she also suggested, and then you start chopping. My technique is a vertical chop. This is what I do in almost all the cases. So you've got a nice hold, and then you chop. You can see that the chop doesn't go through. So you have to keep on doing the lateral separation till you get to see the bottom. So here you can see that I'm chopping. So you do a little bit more lateral separation, go all round till you separate the central hard nucleus core. Once you've separated the central hard nucleus, and till the time you just go around and make multiple chops. Don't chop once and remove, because you need that resistance for chopping. And once you've got the central core out, now you can go ahead and do more of a lateral separation till you remove all the pieces. So this can be done either, see, you can see that here that I'm using the phaco probe, but it's always in the pupillary plane, not in the anterior chamber. So that is also important. Avoid keeping your, there's a tendency for us to go to do an anterior chamber phaco, because that's going to cause more endothelial loss. And throughout the surgery, if you notice, that the anterior chamber is very stable and the phaco-dynamics are working very well. And with this, now you've removed all the cortex, the lens can be inserted. And once the lens is inserted, you can remove the iris hooks and watch the remove all the viscoelastic. Don't remove the iris hooks before, because then you will not be able to see the margin of the rhexis, and you may be putting the lens outside the margin of the rhexis. So remove, after you put the lens, you remove all the iris hooks, and now you can wash thoroughly. Usually there can be a little bit of a stretching of the pupil post using an iris hook, but post-operatively they do constrict to normal size. So the caveats are, use high phaco power. That's very important. You should not push the nucleus, because already these patients who have pseudoexfoliation, have very poor zonules, are prone for zonal dialysis. So minimal manipulation in the bag, high density viscoelastic. You can use, so my go-to is also Viscode, like Dr. Haripriya mentioned. I have no financial interest. Viscode is a combination of good dispersive with cohesive viscoelastic. It's more dispersive actually, so it protects the endothelium, but it also gives quite good space. And then you use, in patients who are not dilated, you can use an iris hook or you can use an adrenaline. Always keep a CTR handy if you come across these patients. So this is another case which I'm going to show you, just to show that you can do these cases without any pupil expanding devices if you use the correct parameters. This patient has a hard cataract and also a white cataract, so there's not going to be any fundal glow. That's again something against us. That's why you have to do staining of the capsule. And once you've stained the capsule, you do multiple quadrant hydrodissection. Don't overhydrate the bag, because already the nucleus is filling the bag. So multiple quadrants, you do a hydrodissection and gently rotate and see whether the nucleus is rotating. Otherwise, you can do a little bit of trench, and then again you can come out and do a hydrodissection. Don't overhydrate. So here I'm again creating a central trench. I'm using a very large sharp chopper. And the sharp chopper helps because it helps us to cleave the nucleus. And once you've done, you see, you can do a multiple quadrant chopping. You don't have to immediately separate like what I'm doing now. You can do multiple quadrant chopping. You remove the central nucleus core. Once you start doing chopping, you can see that the central nucleus core starts separating, and you'll be able to access it better. Once you've done that, you can go ahead and remove the central nucleus core, and then again continue to chop till you reach the margin. Once, see, the other important thing here in this aspect, what I'd say is, at this point, if you switch on the retroillumination in your microscope, you get a very nice red glow. So that allows you to understand the depth to which way you're operating. So here, this is one of my very old videos. I've not done that. But nowadays, the most important thing I do is, beyond this stage, you switch on the retroillumination. So that gives you a very nice glow. So you know your PC is protected. You know there is no PCR. Your reflex is very good. And it also helps you to know where exactly your rhexis margin is. Because sometimes, even if you stain, sometimes these stains do fade away. And it gives you a more control over the surgery. See, throughout, what I want to emphasize in this case, you see that the pupil size has not gone down in spite of doing quite extensive chopping. And that is a trick, because you can operate on any size pupil, provided you understand the phaco-dynamics. Do not touch the pupils at all. Do not overinflate, and also don't make too much of fluctuations in the anterior chamber. That is one cause for the pupil to go down. Otherwise, the pupil can remain like this. The other reason, of course, is what you cannot avoid is in IFIs, it is floppy iris syndrome, where even in the middle of surgery, sometimes you have to convert and use a iris hook or some pupil expanders. So the next case I'm going to show you is a Malugan ring. Malugan ring is made of polypropylene. It has 4 scrolls, something like the tip of a safety pin, and it engages the pupillary margins very atraumatically. It is introduced, it's preloaded and can be introduced through the main port. See, here I'm giving some good viscoelastic. This is the preloaded Malugan ring. You can see the scrolls. These scrolls catch on to the iris margin. And there are 4 scrolls. You can just inject them, and then you can even place them after the injection. You don't have to do it in one go. So you just gently make sure the scrolls act like a paper clip. So they just clip on to the iris. And once you've injected completely, you will get a nice round pupil. So you don't get a square pupil, but you get a nice round pupil. So this iris is a little bit more rigid. So you can see we need to take a little bit more extra pressure for stretching it. Now you have a nice large round pupil. Once you have a large round pupil, there is no problem at all. It's just go ahead with a regular surgery. You can do whatever surgery technique that you're used to in case of hard cataracts, and the procedure will be completed. So the main issue here is the pupil. So that is what I'm stressing on. So this is one way of handling it. So Malyugin rings is widely used. The only downside to it is that it's a little bit expensive and it cannot be reused. So you can use it on patients who can afford it. But iris hooks are not so expensive. There are versions where you can sterilize them and reuse it. And so that works out better in most cases. But this is one excellent technique, and which is very atraumatic to the pupil and does not produce any change in the pupil size throughout the surgery. And then once you go ahead, it doesn't cause any change in the phaco-dynamics as well. And once you have done this and implanted the lens, it can be very easily removed through the same port using the same instrument, which is something like a small clip, and you can just dismantle this paper clips from the iris, and using the same instrument which was used for injecting it, you can see there's a small clip and you can just take it inside and remove it. So coming to the next surgery, this is one of the Indian innovations. It's called as BX. And it's a BX pupil expander. Is very similar. It's called as HEX because it's got hexagonal shape, and Bhattacharjee is the one who did it. So I just want to show you the different, you can see how it looks. So it has got a broad portion as well as multiple tabs, and see this has got a broad portion, and then it has got multiple tabs for holding the iris, and flexible notches. So actually the iris goes into these flexible notches and the tabs come on top, this goes underneath. So basically it creates a hexagonal shape pupil, and it is extremely thin. It's made of very extremely thin material. It's only 0.075 millimeters, and you can see it's flexible. It can be introduced through a side port very nicely, and it can be either used using a manipulator or using something like introducing forceps you can use. It's always better to inflate under the iris a little bit, and you can see there's a platform to hold the BHEX, and then which is introduced. And once it goes inside, you can tuck in the flanges one by one very easily, because it's extremely user-friendly. And you get a hexagonal size pupil of approximately about 6 to 6.5 millimeters, as you can see here. And that is good enough to go ahead with our cataract surgery without the pupil coming into the phaco port. So then once it is done, once the procedure is done, you can disengage these pupil expander, and it can be removed very easily either through the side port or through the main port. And you can see how nicely the pupil has become round, and again it's very atraumatic because it's extremely thin and very user-friendly. So this is a complicated cataract which I showed you earlier, and I'm just going to repeat this surgery. Only thing, I'm going to complete the surgery. I just showed you how it's been expanded. So this is, I'm using a second instrument rod to release all the posterior synechae. And even now you can stretch. Suppose you have come across a situation where you have not having any pupil expanders, you can stretch, but make sure you don't stretch in the direction of the main wound, because that's the area where the iris becomes very weak. And when you're doing the phaco, make sure that even if you go close to the iris, your port is pointing down and not towards the iris, because then the iris is already floppy, it's going to press it into the port. See, you see I'm doing a chopping technique, but my port is pointing slightly down and it's embedded in the nucleus. So no way the iris can press it into the port. So that is a very important trick you learn in case of floppy iris. And use a slow motion phaco. You don't have to really rush and do these things. And keep filling up the anterior chamber with viscoelastic, because that helps to keep the pupil a little bit away and gives you a good control over the whole surgery. And then you can go ahead with the lens implantation. So this, so again, coming to hard cataracts, myotic pupil, the size of the pupil, like I told you, is very relative. It depends upon the surgeon's skill and also the iris tissue properties. The iris is very rigid. Like the first case I showed you, you can go ahead and do it without any pupil expansion. But if it is something like a floppy iris, then you're sure you're going to get into trouble. So depending on that, you can decide whether you want to use a pupil expander or not, and also decide on what is the other comorbidities a patient has, and then go ahead and use a pupil expander. So this is again a very small video showing how you can do a can do the rhexis under the pupillary margin. So in a small pupil, so you get a slightly larger rhexis than the pupillary size, and that avoids any problems related to the small rhexis. So you can see it's just right under the pupillary margin. So it gives us very good access to the nuclear material without any stress on the zonules. So most important features are anterior capsular staining, good hydrodissection. You might have to do multiple quadrant hydrodissection. Nucleus management can be a vertical chop, or you use cold phaco, that is hyperpulse or ellipse or ozzle in these patients. So the intrinsic challenges are poor visibility, fibrotic or fragile anterior capsules, large lens size, adherent cortical capsular adhesions, deficient epinucleus, tenacious leathery fibers, and a thin posterior capsule. So in spite of all these challenges with small pupil and hard cataract, it can be overcome by proper mental preparation by the surgeon and a few simple tricks. Thank you. So I'd like to request Dr. Mohan to come and give his talk on femto in hard cataracts. Any questions? It's made by Swan Bhattacharya.
No,
It's available. I don't know which company it's.
no,
Indian company only is making.
Jojo Surgical.
Okay.
Jojo Surgical.
He sent over a batch of them, so that's why.
No, Jojo Surgical. It's only 1,500 rupees.
It's very
available.
useful.
Yeah. Okay. That was a very nice talk, Sujatha, for illuminating us on various how to manage. I think it's important that you identify the small pupil right in the beginning of the surgery, and probably use the iris expanders right in the beginning of the surgery, especially when you are dealing with a patient with IFIS, because you don't want the pupil to come down on you, especially when you have a hard cataract, and it's going to make your life more difficult. So what I'm going to talk to you in the next maybe 12-15 minutes is flax in hard cataracts, femto laser assisted cataract surgery in rock hard cataracts. These are my financial interests. As you know, the flax is a fantastic platform. It is a very good platform for complex situations. Of course, for regular, the run-of-the-mill, what you call the walk in the park cases also, the flax I'm using that because the safety factor is much better. And especially in white cataracts, Heartbrown cataracts, posterior polar cataracts, subluxated cataracts, Fuchs endothelial dystrophy, NHNT means neither here nor there cataracts, in between cataracts. It's very difficult to chop these cataracts, very difficult to crack these cataracts. I'm going to show you a couple of videos as well. Shallow AC, all these are things. Why flax has become very popular? Because, you know, artificial intelligence is becoming popular. In case of diabetic retinopathy, glaucoma, screening. Can a computer perform better than a human brain? Yes, because what I tell my patients is that my hands are good, My hands are 100% safe. But if you want 150% safety in your case, especially when you have a Heartbrown cataract or a pseudo exfoliation or something, or a subluxated cataract, posterior polar cataract, you want that 150% safety, then probably go in for the flax. And these are the different platforms which are available. I'm using the catalyst which is made by the JMJ. And I always compare the manual phaco and the flax with Sachin and Dhoni. So Sachin is, he's a very good player. Okay, you can't undermine the efforts of what Sachin has done. So manual phaco is very good, fantastic, especially when you have good surgeons like Haripriya and Sujatha and so many Ritu, so many people are here. They're all very good. But Sachin is good only in one format of the game. Okay, he's not a versatile player like Dhoni. Dhoni is good in all formats. So that's the reason why I always compare. The versatility of this flax is something which is really, you have to see to believe it. It's a really incredible technology which is there. So let's see what are the merits. You can have the incision, main side port, the LRI if you want, because even for -1, 1.25, I don't use a toric lens. I put the astigmatic keratotomy of the LRI, which is there in the perfect rexus, nucleus liquefaction, the pre-chop. Somebody was asking about the pre-chop, which is there already. So white cataract, brown, black cataract, subluxated PPC, all these. So what are the problems with the Heartbrown cataract? That is the main objective of this course. It's always a challenge to the phaco surgeons, difficult to crack the nucleus because of the leathery attachments of the posterior nucleoplate. The posterior nucleoplate is so difficult. You can see all these chopping techniques, what Haripriya and Sujatha were showing, that is so difficult to chop or separate the leathery fibers of the posterior. Unless you separate them, okay, you can't bring this nucleus into the anterior chamber, because otherwise you'll have white cornea the next day. So thin posterior capsule, large nucleus, there's absolutely no cortical cushion. That's the reason why the horizontal chop doesn't work. For horizontal chopping, you need to go underneath the rexus margin, and that's the reason why you need to have a good cortical cushion if you want a horizontal chop to be done. So always we do the vertical chop with the sharp chopper, increase in the corneal edema and posterior corneal decompensation, increase in the PCR, nucleus drop, all these problems. Always combine the technology and technique. The technology available in the phaco machines, I think any phaco machine you can put their money now, Indian machines or foreign machines or whatever it is, whether it's Stellaris or Centurion or Signature Pro, whatever, even the Apasonic machines are very good. So these are the brown cataract. You can see here it's like a piece of granite inside the eye, okay? And if you it's such a huge cataract, the entire cataract is completely by the nucleus. The nucleus is more nucleus. Nucleus is as big as the size of the cataract itself. It's almost about 8 to 10 millimeters. And more importantly, the thickness of this lens is about 5 to 6 mm thickness. So that is the reason why I think it's so difficult to operate on these cataracts. If you do a conventional phaco or anything like that, without any cold phaco technology, if you don't use the technique properly, you can end up in a corneal edema. And also the corneal edema doesn't stop the corneal edema. It may clear up in about a couple of weeks or about 1 or 2 months. But you can have something like a TAS, because the corneal edema releases a lot of prostaglandins inside the eye, inflammatory cytokines inside the eye. You can have something like a fibrin reaction. And even 25% of these cases of corneal edema can have a problem in the posterior segment as well. That is a cystoid macular edema. This is just to show you the comparison between a post-operative manual phaco, corneal edema, or a femtophaco, wherein you can see the day one, the clear corneas. Why it's clear? Because you can see here, I'm just showing you one case wherein there's a grade 3 to 4 cataract. You can see the rexus is already done. Whatever size of the rexus you want, whether it is 5.1, 5, 5.2, 5.3, little. So already it's a pre-chopped. We can make it 6 quadrants or 8 quadrants. I normally make it 8 quadrants. You can see here I'm chopping, but more importantly I'm using a very, very straight almost a blunt instrument like a Sinskey hook, which is not very, very long also, and the Sinskey hook which is normally used to dial the lenses. I'm just using that because already it's pre-chopped. You can see that I just have to go in, bury. I don't have to use much phaco power at all. And all the way the chop is gone there. The very fact that you get the gas bubbles from there, it means that the posterior nuclear plate is opened up very nicely. You can see that how beautifully all the pieces are already there. It's all the pre-chop technique which has been described by earlier Akashi. It is done by the problem with the pre-chop. What Akashi does is with the instrument, whereas here it is done with the laser. So you can see another patient with a grade 4, grade 5 cataract, and you can see I'm doing the incision. The incision is a true triplanar incision, which is there, the main port as well as the side port. The rexus is already there, and the rexus is about 5.2 millimeter. Make it slightly larger because I want that space in the posterior chamber for me to chop these cataracts. You can see here I do a gentle hydrodissection. It will be a very gentle because already the pneumodissection is already there, and these cataracts are quite hard as well, very big, very thick. You can see here I'm just using my sharp chopper, but the sharp chopper is not doing much force at all. I'm just opening up the cleavage planes which are already there, and the gas bubbles are getting released. Why the gas bubbles are released? The gas bubbles are going all the way, it's cutting all the way to the posterior nuclear plate, and that is the reason why you are getting all these problems. The advantages of the, as you can see, I'm just separating these 8 pieces or the octants, and I'm using very less phaco power, and that's the reason. And then it's really a cakewalk for you. So now and then I inject viscoat. This is something which Sujatha also mentioned, viscoat into the anterior chamber, because I don't want, you can use, I'm using in this case a Stellaris machine. Whatever machine you're comfortable, whether it's a peristaltic, Venturi, all doesn't matter at all. So you just have to combine the technology with the technique, and you can see you're going ahead with this thing. The effective phaco time is only 13 seconds. If you had done a manual one, it would have been about around almost a minute. You can see here, this is a brown cataract. You can see here again, increase, it's almost grade 5, grade 6 cataract. When I presented this in the ACRS, Howard Fine once told, it is in the US, it is called grade 13, these cataracts. So this is something which is, they don't see that these types of cataracts at all there. It's all Californian cataracts, grade 1, grade 2. So something which is, so you can see here how beautifully the cleavage planes are opening up, and it's going all the way, and the catalyst is probably the best machine in this, very powerful, and especially for hard cataracts, and because the Lensex is not as powerful as the catalyst. I don't have any financial literacy, but it's really fantastic. You can see here, you just have to stay in the center, and stay in automatically the pieces will come to you, and because the pre-chop is being done, and in a Venturi system, there's all these machines are higher end machines. The stability of the chamber is very good. Of course, as Haripriya was rightly mentioning, you can even you can see this is a femto brown black cataract. You can see it's a grade 6 cataract. You can't see the red glow. It's very difficult to do even a rexus in these patients. And I've done the rexus already. The pre-chop is done, and going ahead with the chopping, just burying the tip and going ahead. Very simple opening up. See how it's beautifully opening up. Otherwise, I have to give lot of lateral rectus forces. I have to give lot of phaco power every time you bury, and you have to hold the right piece. In this case, you don't have to. Just have to go in and just open it up. Open it already pre-chopped. Just open it up, and the rest is it's all. It's a child's play for anybody. Just because if I can do it, I'm sure everybody can do it. It's not a very big issue. So this is possible because of the technology which is available to you, which is, I think, it's going to become very popular, this flax, because once they reduce these, you can see this is a black cataract. I'm doing a manual phaco, just to show you the comparison. I'm doing a manual phaco, I'm doing a trench, and then I'm going ahead and using my sharp chopper, which is about 2 millimeter for back cataracts. I have the Mohan Rajan chopper, which is made by Appaswamy. I have 1.5, 1.75, 2 millimeter. The 2 millimeter chopper, if you want to stab somebody in the abdomen, you can use this 2 millimeter chopper as well. It's so scary to see under the, but these cataracts, you'll not have don't have any fear of penetrating this posterior capsule at all. Because as I told you, these cataracts are very thick, 5 millimeter thickness, 5 to 6 millimeter thickness. You can see here, so much of time is being taken to actually chop these cataracts. Maybe it's a good idea to do even SICS, many people can do that, but I do only phaco in these patients because I feel the stability, especially these patients come for a pre-myoils. You can see how much time it's taking, but still it's possible. You can see this thing is EPT is almost 1 minute time. You can see again, just to show you a black cataract with a femto. Femto is only about 1/4 of the time which is taken. Again, rhexis is done. The pre-chop octants is done, that is 8 quadrants are done. Then I'm going chopping straight away. Carefully, you have to rotate this cataracts, this nucleus. You can see how beautifully it's opening up. Okay, just have to stay there and open up the cleavage plane. You can use any instrument, even a blunt instrument. I'm just showing that because I'm used to these choppers regularly. So that is the reason why I'm just wanted to show you. And you can get consistently clear corneas. You can see the clear cornea in all these are patients on day 1, day 2 of patients who got all brown black cataracts. They come out with consistently clear corneas in all these patients. You can see a pristine wound as well. There's absolutely no wound burn. If you see them on the day 2, day 1 or day 2, you know which eye is got operated. Again, just to show you another patient with a brown cataract. Again, fuchs endothelial probably is one of the best indications for flax. You can see this is a patient with a very dense cataract and a fuchs endothelial dystrophy. The patient required a toric lens as well. I'm using a Callisto system there, and you can see here how because it already does the rhexis. It already does the nucleus division. It makes the life easy for you. And you can see here, I just doing a small this thing and then going ahead, very less phaco power. I mean, removing the entire cataract. And you can see that it's very, very easy. And despite the fact the patient had very low endothelial count, you can see the 2 hours post-operatively and the day 2, how the cornea is crystal clear, and subsequently after a week also. Just to show you the small pupil. My small pupil, if it's very small pupil, you can obviously do femtocataract, but it's a little larger than about 5.7 or 8 millimeter, because I need to get a rhexis of about 4.7 millimeter. So the pupil, the rhexis will always be smaller than the 1 millimeter smaller than the size of the pupil, which you can adjust in catalyst mission. So that is, I think, one of the biggest advantages to have this small pupil. We have a small pupil, because the nucleus, the catalyst mission cuts beyond the margin of the rhexis also. So you have a small pupil and you have a good rhexis also, which is there, and pre-cut cataract, which makes your life very, very easy. So reduce surgical time, reduce effective phaco time, more precision, clearer corneas day 1, reduce complications as well. Just to show you Heartbrown cataract with sublex, I'm sure Nivian will correct. Just to show this, a patient had a shuttlecock injury 20 years back, you can see here, and this shuttlecock injury had a subluxated total white cataract. Okay, if you're going to do this cataract on a regular basis, it's going to be so difficult for you to even do the rhexis, because for the rhexis you need support. Okay, from the peripheral resistance has to come. But if you did a femto, you can see here the rhexis is already there. I just make the incision there, and then I pull out most of the times, 99.5% of the time, it's a free-floating rhexis. You can see here, I'm just putting the side port and supporting that area with the iris hooks there. I know capsular hooks are always better, but this is just the localized zonal dialysis which is there. And you can see here, already it's pre-cut. Okay, so I have to go in and just pick up the cataracts. You can see I'm picking up the cataracts very easily. Again, separation is there. I just have to go in and separate, and you can see here how I'm doing it very, without any problem at all. And then going ahead with the, So life becomes very easy in this particular patient had traumatic mydriasis. So I put a MA60 lens, a multi-piece lens in the sulcus, and captured that in the bag, and then went ahead with the single pass 4-throw pupilloplasty as well. So just to show you this, again, we are talking about white cataracts, Argentina flag sign, okay? The Argentina flag sign is a type 1 cataract where the interlenticular pressure is very high. It's not only an interlenticular pressure, it is also the pressure from the vitreous cavity as well, the positive vitreous pressure. There are 4 components. One, the pressure underneath the anterior capsule. The nucleus is bulky. and there pressure in front of the posterior capsule, which pushes the nucleus as soon as you make a nick in the anterior capsule. So this Argentine flag sign can be prevented if you have a Zepto, but the problem is Zepto is an invasive technique, and but it works very well. Or you can do, this is what Sujatha was talking about, you can just do a needle aspiration of the front component. It takes care of the anterior, that is the first component which is there. You can just do and then go ahead with the rexis, which is possible. It works about 50-60% of the time. Or you can use a puncho rexis, which works in my hands. It works about 100% of the time. But more important than the puncho rexis is the femto cataract. If you have access to femto, even the patients cannot pay, go for this, because you can get a very good, you don't have to do a double rexis, you can just have the size of the rexis, 5 point. If you have a bigger hard cataract, white cataract, and if you have a bigger rexis, it makes your life very easy, because you have the more space in the posterior chamber to remove these cataracts. You can see here, only thing is to look for skip areas when you do this thing. Many times it may not be free floating rexis. There can be small areas which can be attached, so don't try to pull it out. So take home message, flax is fantastic technology. The cost is going to come down, and definitely it's going to be user friendly, and more people will start using it in the future. White cataracts, Heartbrown cataracts, posterior polar cataracts, subluxated, fuchs endothelial, and the in-between cataracts also. Safety, precision, bladeless, consistency, wow effect, good platform for marketing, differentiation practice. Thank you again, Sujatha. Thank you, the Chairman Scientific Committee and the Scientific Committee of AIOS for the wonderful opportunity.
Thank you, Dr. Mohan. We have the last speaker waiting, Dr. Nivian. And please.
Where you don't have flags, so any experience with myloop or with mechanical
Pre-chopping.
Yeah.
We're just discussing it, the previous talk after.
MyLoop can,
MyLoop is, it needs, I think, a learning curve, because I've seen quite a lot of good demonstrations, but don't have a personal experience in it.
MyLoop is good. Only thing is, MyLoop has got a learning curve. The problem is MyLoop is that you need to have a good rexis, that's fine, but you have to make sure, because these don't have any cortical cushions, so you need to make sure that you are in the correct plane. And then we have seen the worst complications with MyLoop, not with us, but with referred from other people. But it's it's one of the good promising technologies. Yeah, but I would suggest that if you don't have flax, yes, manual phaco, the way I showed the vertical chop technique, use the sharp chopper, because if you're going to use the vertical chopping technique, use the sharp chopper. If you're going to use the horizontal chopping, don't use sharp chopper, use a blunt chopper. Okay? And sharp chopper, Mohan Rajan chopper, if you want, I can send it across to you.
Thank you, Dr. Mohan. I'd like to introduce Dr. Nivian. He's an innovator, excellent surgeon, very young but very innovative, and he's a chairman of M&I Hospital, Chennai. He's going to speak on subluxated heart cataracts.
Thank you, ma'am. First of all, it's very difficult to do heart cataracts, and on top of that, very difficult to talk after Mohan Rajan sir showed all the videos on black cataracts. He made it look so easy, I think so. No matter what cataracts I showed, not look hard enough. So, but then basically my talk is just on how to manage heart cataracts when you have other complications associated with it, like a zonal dialysis or a subjaculated lens. So then it multiplies the problem. So you can see here is a case of an iris coloboma. You can see the flattening here and the loss of zonules along with the NS3 to 4 brown cataract. So the basic principles of managing any of these cases are going to be the same. Getting the good rexis, because then it has two roles to play. One, you want a slightly smaller rexis so that in case you have a rupture or anything, you can do a capture. The second thing is, in this area where the zonular weakness is there, sometimes it tends to run away because there is no support. So we should not tend to go to the periphery. You can make it slight. It may look as if eccentric, but it is actually not eccentric. It is because of the zonules are not there. The nucleus is slightly shifted in the opposite direction. So it gives you a feeling that you're actually going off center, and we should be careful about those two things. The next thing is do everything slowly, careful slow hydrodissection where you can see this fluid wave. I'm not repeating it, and slow rotation. Again, the choice of phaco technique, I always prefer whichever the comfortable surgeon is. So most of the times you do a stop and chop, there's nothing wrong if you're comfortable with the 4 quadrant or the direct chop. But they say when you do the direct chop, there is less energy and less stress on the zonules. Here I do something called the modified chop. When I shifted from stop and chop to direct chop, I haven't found it initially difficult. So what we used to do is make a small burr hole superiorly, if you can see here. So what this small burr hole superiorly does is it debulks the nucleus and also gives us some space to go and embed that phaco tip inside. And almost we have reached halfway through. So this is another point I learned, that you should need a better exposure of the phaco tip. If you have seen all Mohan Rajan sir's video, because initially 5 years back when I used to present, he used to point out and tell me, when I used to ask him that I'm finding it difficult to do a direct chop, he says if you have less exposure, it tends to slip when you try to crack it. So have a good exposure, good phaco power can be actually increased even though you're just burying it. So you can have a good phaco power and just slightly lift up and initiate the chop. But here again, because you have the zonular weakness, everything is slow, not too much of a lateral separation. And then slowly dial it. And usually in these hard cataracts, once I get a chop on either side, I usually tend to remove the pieces because I want to have some space there so I can see the red glow and do the other pieces. But in these types of zonular dialysis cases or weakness cases, I do not remove the pieces because sometimes we know where there is loss of zonules, the bag can actually collapse. So that can actually get caught into the phaco probe. So in these particular cases, I don't prefer to do that. I like to keep the pieces there inside. So in the phacoemulsification is almost the same, only thing in the back phaco, I would rather prefer to do it slightly in the pupillary plane or even in the hamtrate chain, just trying to stay away. And then without removing your phaco handpiece, make sure you inject good amount of viscoelastics because you don't want any flattening of the chamber so that you see those defects there, the vitreous can actually prolapse through that area. And then cortex aspiration, whether coaxial or bimanual, I'm a bimanual coaxial person. So do it gently, just strip the cortex. I call it cortical stripping. Just hold on to the anterior cortical fibers, bring it to the center, then aspirate. Because during cortical aspiration, more zonules can actually break, and then that is when you see what was 1 quadrant can actually extend up to 2 quadrants. The next point is the using of the CTR. So any of these, any 2 clock hours or up to 4 clock hours, I think CTR is really useful and it can be easily done by any surgeon. There are various methods. I use the ski hoop to make sure it goes into the bag. You can also use the forceps to guide them inside the capsular bag. But make sure that the leading haptic goes and make sure it goes into the bag, because sometimes if it goes in sulcus, it's very difficult to retrieve them. You actually lose them. Actually, you'll have to do another CTR. So once the CTR is done, choice of IOL, again a single piece hydrophobic or a 3-piece lens. But the trick here again is to make sure those haptics go into the area where the zonular weakness is. And I try to avoid, usually what we do is the technique of dialing the lenses, but in this case we don't dial the lenses. It is safer to just dip it down and place it and then bend those haptics. And so that is how the positioning of the lenses. So these are just some of the points, take home thing to know when there is a combination of these hard cataracts with the zonular dialysis, usage of a CTR. The next case, I'll just show you if the dialysis is a little more, how you can combine a CTR with a CTS. I think I had the similar video in the other session, managing ZD, I think. So here again, what is different is, because it was a larger clock hour, we're introducing the CTR first to stabilize before even doing the phacoemulsification. And once the lens is kept inside, you can see the maximum area of zonular dialysis is here. So we're trying to fix it along with the bag. We make those reverse flaps for the Hoffman's pocket. And then use the 10-0 Proline needle. And using the 23 gauge needle, I'm bringing out the needle. The other end of the needle is brought out through the main wound. And the CTS segment has an eyelet there inside. So this I'm threading it into the eyelet of the CTS segment. So once the loop is passed inside, the second needle is also brought out through the sclera there. So now when you gently pull this, the entire CTS segment is pushed into the tray chamber. And then make sure it goes into the bag in the area where you have the maximum weakness. So once you can see it's inserted into the bag. And then both the ends are tight. You can see the bag is more stable. So I think this is the last case in which you can see sometimes we'll end up with a combination of hard cataract, small pupil, weak bag, and this is like a phacolytic glaucoma where all the leaking proteinaceous materials are in the antechamber. So again, the trick is you make sure that you keep most of the things ready. It is like going to a battle, make sure you have all the things ready, like your claw lenses or your secondary lenses. So once I wash the antechamber, you can see there's a small hard nucleus. So in these cases, I prefer to do a limbal incision, so in case I want to convert. The third different thing is doing the envelope technique, because I saw some amount of calcification here. So I use the vanas to make a nick. And you should understand in these weak bags, sometimes you don't have this counter traction, so it is not easy. You can see this elasticity of the anterior capsule. So I stopped that side and went to the other side. The other side was slightly better. We were able to get it till that area where you can see the calcification is there. So once that was done, these are the small hard cataracts. Sometimes these are very difficult, and you can see there's so much of space in the bag is also rolling here. So what I did differently here was just made sure I filled the bag and then put the lens under the nucleus. So what this lens does, if you can get it in the bag, is one, it stretches the bag. I think there can always be controversy, some may not agree. So, but once you put it in the bag, it actually stretches the bag. And then, but make sure that the nucleus is a small nucleus. It cannot be done if the nucleus volume is a large, hard nucleus. So just maneuvering, making sure that I don't lose this nucleus. So then chopping it was difficult because the little space was also less in the antechamber. At the same time, care must have been taken to the iris. One mistake I did here retrospectively thinking is, I think before Mohan sir pointed out, is I didn't use iris hooks. I think that's what exactly you're thinking right now. So I admit it was a mistake, but sometimes when the adrenaline is rushing and you're doing the thing, sometimes we to forget. But I was careful enough to just to bring it antechamber and break it into smaller fragments. So the IOL below is acting like a scaffold, and it is just making sure that the bag doesn't collapse, at the same time not losing these the nucleus pieces. So once the phacoemulsification is done, you can see slight decentration there. That is where the zonules were weak. So in any doubtful cases, in any of these cases, I would always tell everybody to use tricot. Just stain it and see, because no harm. And once you stain and wash it, if there is vitreous, you will definitely see like this, the remnants of the tricot crystal stuck onto the vitreous. So rather than our naked eye, always stain and wash it away to see in any of these doubtful cases. And then using the cutter, make sure the entire vitreous is removed. So one side you use the infusion, and the other side you can use the cutter. Most of the phaco machines have the cutters, so all phaco machines actually have. In this particular case, because it was phacolytic glaucoma, I did a small PI. Others on a routine case wouldn't have done it. So once the vitreous was cut, you can see the lens well centered into the bag, and I think this was the best that I could do for this particular case. And eventually she did well up to 624 vision she had. So the last thing, I think, we were talking about hard cataracts, but when you have a subluxated cataract, the only option is to remove the entire lens and then place it with any secondary IOL. This particular thing is had the new lens that had invented the CMT flex lens. Just show you the lens alone. So once the lensectomy was done, this was a soft cataract, but if you have harder cataracts with subluxation as a topic that was given to me, sometimes you can do SACS and then remove the entire lens. So this is a single piece hydrophilic lens, the T junctions that you can see on either side. So this is a new lens design that we had come up with the treatment of any of the secondary aphakias, or even on table when you have such complications. So inject the lens through a clear corneal incision, and using this Prerequisites T-flex forceps, just grasp the head of it. At this time, do not pull the lens, just inject the rest of the lens inside. So once the lens is injected inside, just pull it out through the sclerostomy. You can see the pop of the T haptics that come up. So the special T just opens up, and then this prevents the lens from falling back inside. So this is just an animation clip to show how it is done. So grasp the head and then just pull it out of the sclerostomy. So the same can be repeated on the other side. and that is almost the end of the surgery. So, thank you. Any questions or suggestions?
Yeah, so in your first case, like you made your main incision right directly opposite your area of zonular weakness.
Correct.
Because see, most of your chopping is in that direction.
Correct.
Maybe if you had done a
Temporal. How does like? It's a good question, but I don't know. Does it help? Because she's telling you to avoid that area of the zodi
I
when.
would also do that. Because you don't want the maximum stress is on the 6 o'clock position. Wherever you are entering is 12 o'clock. Okay? And at 6 o'clock. I think you should be away from the area of zone dialysis. I don't remember the details.
She's saying wherever the zonal dialysis is, so you.
Where was
Exactly. Like from 6 to...
exactly 6 o'clock.
I think I was doing temporal and I mean I was doing superior. Correct.
Was it nasal?
I think it was inferior. I was doing superiorly.
Normally you do temporal.
Normally we do temporal, but any of these complicated cases we prefer to sit superior.
What type of case was it? Was it because of trauma and the subluxation?
The first case was just a coloboma, ma'am. Just a coloboma with a hard cataract with the iris defect.
That's the reason why he could get away without putting CPR, because the rest of the zonules were very strong. Only that zonules were missing.
No, I just meant to point out that where you have a case where you have subluxation, it's better to put
That's a nice, good point actually.
Absolutely. But got away with it because the rest of the zonules were strong. And also when you do it in this degenerative disease like Marfan syndrome and all that, with so much of manipulation, definitely the bag would have come out. Because the rest of the zonules are very strong, he got away with it. What you're saying is a good point.
Yeah.
The other thing
Away
is,
from the-
if you're using this T-flex lens, you had a posterior infusion. For anti-segment surgeons, do you recommend using an AC?
Yes, ma'am. You can do it with the AC maintainer also. In 2 cases, we have done it even after SAC, even without an AC maintainer, just with the infusion itself in the AC, we can do it. The whole point is that the anterior chamber should be formed. Otherwise, it becomes very difficult if the eyeball collapses. So wherever we do a little bit of vitrectomy, the infusion is better, actually.
And do you put glue after putting the leaflets, or
See, again, here particularly that the lens design is what holds it back less. So the glue is mainly for the flap. So you can use glue or you can use sutures, or sometimes I just cautery the conjunctiva and just leave it like that. So, okay, any of the thing. Appasamy is doing the lens. It's available in the market. It's patented and it's come out this year. We had a delay. Yes, ma'am. We had a delay because of the COVID by 1 year, but now it's out.
You are taking scleral flaps now. How can you just put cautery the connector? You need to close that scleral flap.
You don't suture the flaps, you're saying, sir. If you're not putting glue.
No. What I'm trying to say is,
We put glue for most.
how will the scleral flap suppose?
If you don't.
The conjunctiva, how will the scleral
In my posters, we have seen, I think the normal healing mechanism is in there. Because most of the cases we have done 80% glue, but slowly when people start asking is it necessary to use the glue, so before we were doing sutures, and then certain cases we're just doing only the cautery. I think maybe the autologous blood or whatever is there causes the normal fibrosis that occurs. Here,
what is the gauge of
23 gauge, ma'am. Yeah.
What is the IOL power calculation? Do you do like normal lens or is it
That's a good question. We do a normal lens here. The A constant 118.0 we came up there. But why? Because again it is sitting maybe slightly in front of the back, but we've given a design where there is an angulation. So it doesn't just sit behind the, so it has a slight, so that there can be some amount of pupil dilatation also without any pigment disruption.
you use the
Same A constant, no, we don't change.
to a PI?
No, ma'am. No, so far. Thank you.
subluxated cataract is well managed. Only thing is, what I would do is differently from what you have shown is that the area in the beginning itself I'll support that either with the capsular hooks or the iris hooks in that area. Okay. Then proceed with the phaco. Then at the end probably I will put a CT.
I was quite surprised also that you got away without any extension of such a large, about 4 clock hours. Then, of course, the case was a coloboma. That's why you got away with it. But any other case, I think probably you should have to put
Capsular
a CTR.
hooks will help in some of these cases
Capsular
when you
hooks
have a
will
large
help. Yes,
thing,
yes,
sir.
capsular hooks.
Yes, capsular hooks definitely will help. or even iris hooks. The only thing is, when you're using, see, iris hooks is not meant for the capsule because it rests on the capsular rexus margin.
Some tear the
The
anterior
only thing
capsule.
is, don't keep too much of traction with the iris hooks and don't keep it for too long also. So the two things you should avoid when you're using iris hooks for the capsular bag. So don't use too much of traction, don't keep it for too long. Ideally, it will be capsular hooks. The problem is we don't have capsular hooks at that time, or sometimes it's a little bulky.
Bulky.
That is another thing. So iris hooks are much.
Actually, this type of case is probably an ideal case for femtocataracts, because it does most of the procedures, stress on the zonules.
I showed that particular thing, because the rexus is the key thing, and also the nucleus division. You don't have to do anything in femto, because everything the the mission does for you. The rexus is done, the nucleus liquefaction is done. You just have to go and pick it up.
Maybe I should arrange a day where I can send my patients across for the femto.
Fantastic surgeries by Dr. Nevian. Any other questions?
One more. Dr. Nevian, in your last case, where did the vitreous prolapse come from?
That phacolytic, yes ma'am, see I am just assuming in these cases the bags are weak and there are some.
In such a case, putting your lens first is actually quite a
Risky thing. Yes.
It is, that's why I say each case differs, because I have put this and then.
had very poor visualization, so you know.
Absolutely. See, what happened was when you were doing it, you were stretching the bag. The whole bag was going towards one side. That's why there was a vitreous prolapse. That's a little bit risky. I was quite surprised.
I agree ma'am, but I've done 5 cases in which I've lost the bag in one case.
Done everything correctly. The only thing which he himself mentioned is that he should have used iris hooks.
To see better.
I'll tell you, this is I think which is a take-home message for everybody. If you can learn one thing, that if you have a PCR, okay, the pupil becomes small. Don't try to do a vitrectomy and put a lens. Then next day you'll see the lens on the macula, because you would have put the lens in underneath the rexus margin. It should have been in front of the rexus margin. So at that time, use iris hooks. Use iris hooks. You find out where exactly your sulcus is before you put the lens. Similarly, here also, in the beginning itself, you put iris hooks and expand the pupil.
Good visualization is the key.
Visualization is the key. Then you could have gone out with the IOL scaffold technique is a good technique, because the nucleus is small. Nucleus is big means IOL scaffold will be a problem. And you will end up in a cornea which is really
Sometimes during that last piece I've had the whole bag. Sometimes it's not because of that. There are weak zonules, and as you're doing the chamber fluctuation is there, the bag tends to roll and come during the hin. So there have been articles that this is one way that the lens keeps the bag in stretch. There are other questions whether the phaco energy will cause, but I think we can be away from, because the phaco is done mostly in the anterior chamber almost. So it's a compromise between the cornea and the lens.
Yes, one question.
Hypermature Morganian
Correct.
cataracts.
Yeah,
Where you have very
small.
Yes, Doctor.
The nucleus management, proper technique in chopping is the ideal technique. Use the chop and chop is.
I think because first thing when I started, like comfort of the surgeon, whichever technique you are comfortable will be first. But I think the sir will agree that direct chop I think causes one less amount of phaco energy that is used, and also less stress on the zonules. The time, overall time is also lesser.
The problem with this heartbrown cataract is that you need to use, suppose you are doing stop and chop, you need to go 90% or 95% of the depth to do a trench. So every time you go do a trench, you are going to use so much of phaco power, and it is going to increase your surgical time. And chopping, it produces less stress on the capsular bag, number one. Number two, you don't have to trench, so less amount of phaco power. Especially with the hyperpulse, the pulse modulation, the micropulse, which is available in all the machines now, and with the good viscoelastics, you can get away with a very nice clear cornea for all these patients.
I learned a lot from Mohan sir and Sujatha Mohan.
Thank you. Thanks a lot, and thanks. Though we had only a handful of people, it was really good discussion, and thank you once again. Yeah.